Now, with medical records, it's important to know that everything in a medical record is about documentation. So just as it says here, that the medical assistant's role and duties include documentation, and if it isn't documented, it didn't happen. And so really what that means is that if something is not written in the chart, unfortunately, our verbal confirmation to something existing, it doesn't matter. It has to be written in the patient's medical record. In fact, so much so, I'd rather have you all over document than under document. More is better. So maintenance also going to be something important in medical records, and that's verifying accuracy. Verifying accuracy has to do with that documentation. So this is why we document when things occur. We don't try to rely on our own memory and discharge the patient and go back and document and charts afterwards. We do all of our written documentation in the moment as it's happening, so that we do have accuracy. And then the very last term there in red is releasing. Releasing is something that's going to be important to make sure that we're doing correctly, because we need to have signatures and verification before we can release any patient information from a medical record. Medical records are really books that belong to the provider, the healthcare provider, but written about the patient. Oftentimes patients struggle with this because they think that the medical records belong to them, and really they belong to the provider. Yes, it is their information that is in the medical record, but all of that information belongs to the provider. Doesn't mean that our patients don't have access to their charts. They do. We just have to follow proper protocol before we release anything from a medical record. Now, for legal guidelines for patient records, not only do we not have the ability to release information without following proper protocol, i.e. getting signatures from patients that we would need, we have to remember also as well that these medical records could eventually be used in a medical malpractice case. So this goes back to the terms of documentation and verifying for accuracy, because you never know when these charts may need to be pulled for the information that you have documented inside. Sometimes, unfortunately, there's a term, it's at the bottom there, called non-compliant patients. Sometimes we end up dealing with patients that are non-compliant. And this means that perhaps the doctor has given specific orders for this patient, maybe a medication they need to follow, maybe a treatment plan, and they're just not following doctor's orders. Sometimes those patients, not all the time, but sometimes those patients will come back. Things didn't work out as they had expected. Lo and behold, we go and we pull the chart, look at it. They've been non-compliant. They weren't taking their medication. They weren't following up. And so, of course, if that were the case, that medical malpractice claim wouldn't have anything to stand on. Now, let's look at the contents of a patient's medical records. What we can expect to see is first the patient's medical history, and that's going to be their current medical history as well as their past medical history. Any past illnesses, any surgeries that they've had, their family medical history, all the way back to their maternal and paternal grandparents. Their social history will also be included. Are they on any particular diets? Do they exercise on a regular basis? Are they smokers? Are they using alcohol? Are they using drugs, whether they're over the counter, legal or illegal? We would want to ask those questions and document as such. Now, we have a term here, chief complaint. And with the chief complaint, that is what the patient is coming in to be seen for that day, that appointment. Now, typically, each patient is really allowed one chief complaint. So if they come in and their chief complaint is they have back pain, it is not unusual for them to say, I'm here for my back, but oh, while I'm here, can the doctor check my leg? I've had some issues with my leg. That would be 2 chief complaints. And so before you document more than one chief complaint, you're going to want to verify to make sure that that's acceptable by your provider, because oftentimes providers bill for one service at a time. So if a patient has more than one chief complaint, while I'm sure they wouldn't mind seeing them, even better, they'd like to get paid for their services. And so what would generally happen is if the provider is okay with it, they'll ask you to maybe establish 2 different documentations, 2 SOAP notes or 2 Cheddar notes that we're going to talk about today, just so that they can bill for those chief complaints separately. When a patient gives you a chief complaint, make sure that you document it in their own words. So exactly what they tell you, and they can get kind of funny with them after a while, but exactly what they tell you, you're going to document patient states, and whatever it is that they're stating is their chief complaint. So if the patient states, I feel horrible, that's what you can document. Patient states, quote, I feel horrible. And that's okay. As long as it's in quotes, it's in the patient's own words. Also in the contents of medical records, we're going to see any lab results, any past tests they've had, patient's written request for authorizing release of records. Anything that leaves a patient's chart has to be authorized by the patient beforehand. If we're sending them to a specialist, if we're sending them to a lab, anything in that chart needs to be authorized. And so we would always check for that before we sent a patient's chart from one office to another. And that is a law underneath what's called HIPAA. And we'll talk a lot about HIPAA as we go along, but it has to do with patient confidentiality and protecting patients' records. Moving forward, you may also see hospital discharge forms, any phone conversations, text conversations, emails also going to be listed, specialist evaluations, and then again, any consent forms that the patient may have, any living wills, anything of that sort, that would also be included in the patient's medical records. Now, the physical examination form is also called a review of systems. This is something that we don't document, and it's for the provider. And as we went through all of the systems yesterday, we talked about, this is an opportunity for the patient and the provider to be able to discuss each individual system and any complications with illnesses they may be experiencing. After the review of systems is done, this allows the provider to be able to hopefully come up with a diagnosis and a treatment plan. That will also be in the medical records. And with the doctor's diagnosis, you'll find the options, any instructions they may have given the patient, any medication that's been prescribed, and any special instructions as far as following up, maybe following up with a specialist, maybe making another appointment and coming back in 3 months. All of that would be documented underneath the treatment plan, as well as any comments or impressions that the provider may have.